back by popular demand, since we can't have live boot camps, this is the first of a series of videos that I'm creating PowerPoints for that will get you through everything that you need to be prepared for your comp predictor and pass your boards, okay? So this is pharmacology, medications that you must know. And I'm doing it broken down by body system. And the first body system, cardiac, my favorite. So with cardiovascular meds, follow along. The first group are anti-lipemics. Remember, the word lipid means fat. So an anti-lipemic is a drug that fights against fat in the blood. And usually what we're talking about is cholesterol. So the first one I want to talk about is called cholestyramine. This is not a real common one, but I have seen it asked on ATI occasionally, so it's included and you need to know about it. Basically, it's not a standalone drug. It's a medication that's used as an adjunct, usually with a statin, torvastatin, simvastatin, et cetera, et cetera. As far as adverse effects, there really aren't any on the system systemically. Can cause constipation, but you must be reviewing liver function tests on the patient. And this medication should be dissolved in either water or applesauce to prevent irritation to the patient's esophagus. And that's it for that one. The next one that you need to know about, and this is a big one, the statins, that whole family of drugs, torvastatin, simvastatin, lovastatin. So statin drugs lower cholesterol, that's the intent. They basically work on the liver, so it is critical that liver function tests like AST and ALT are done on a regular basis. And what you need to know, statins don't like grapefruit juice. Instruct the patient, don't take grapefruit juice. As far as when they should take it, statins should be taken at night, preferably at bedtime or at the very least after dinner. They're metabolized better at night. And the other thing is the most common and actually deadly possible adverse effect is rhabdomyolysis. Rhabdomyolysis is a breakdown or deterioration of muscle tissue that can occur spontaneously as a side effect of these statin drugs. So you instruct the patient, if they have a new onset of muscle pain, muscle cramps, like Charlie horses or something, muscle weakness, they need to stop the drug, contact a healthcare provider immediately because that can be deadly, okay? The next drug that we will talk about in our group of anti-lipemics is niacin. And niacin is a B vitamin. It's really not a medication per se. It's vitamin B3, but it has anti-lipemic properties as well. So in other words, when used in adjunct or concomitantly with another medication, it really does wonders for helping to aid in lowering the LDL, which is that bad cholesterol. Remember, low-density lipoprotein, LDL, bad cholesterol. High-density lipoprotein, HDL, good cholesterol, because H stands for healthy. Okay, so don't forget that. So with niacin, it's a pretty harmless drug. It's a water-soluble vitamin, so it can't become toxic, but it does cause a side effect, a feeling of warmth and flushing that will come over the patient. Easy fix, instruct the patient. Take one full-strength aspirin, 325 milligram aspirin, 30 minutes before taking the niacin, and you can totally avoid that side effect of flushing. That's it for anti-lipemics. The next classification, antihypertensives, and then we have subclassifications or categories. First one I want to talk about are the ACE inhibitors, angiotensin converting enzyme inhibitors. So these work on the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone system that's happening in the kidneys all the time. That's the system that's working constantly to manage fluid balance in the body. By managing how much fluid you hang on to or get rid of, thereby it manages your blood pressure. Think about it. Peripheral resistance, that can happen. Increased fluid retention puts pressure on the arteries, so the heart has to work harder to push the blood through, hence higher blood pressure. When we decrease peripheral resistance, then heart doesn't have to work so hard, blood pressure will come down. So your lungs and your kidneys are biffy, BFF. They work together. And the lungs make something called angiotensin converting enzyme and send it to the kidneys so that the kidneys, when the renin is released and angiotensin 1 is stimulated to be produced, the angiotensin 1 will convert to angiotensin 2 with that ACE that came from the lungs, that angiotensin converting enzyme. And when that happens, that whole process just continues all the way through to the end where antidiuretic hormone is released. Remember, if a diuretic makes you pee, an antidiuretic makes you not pee. And so by stopping that whole flow of renin, angiotensin 1, angiotensin 2, what we do is we stop the production of antidiuretic hormone, and thereby the patient does get rid of some excess fluid. Don't confuse this with a diuretic. It's not the same thing, okay? But doing that lowers the patient's blood pressure. It's important to know side effects. Big one, dry cough. All those prils, lisinopril, enalapril, captopril, those are the ACE inhibitors, and they can cause a dry cough. If it is persistent and nagging and interfering with the patient's life, they may have to come off of it. The other side effect, potentially, they are potassium sparing, so they can cause hyperkalemia. And when you think potassium, you think muscle. And so with hyperkalemia, you're putting the patient at risk for an MI, myocardial infarction, right? A heart attack. So make sure that you're monitoring patients' potassium levels, normal potassium level, 3.5 to 5.0. The other thing that they can cause is angioedema. Angioedema is a swelling about the face, the mouth, the pharynx, the lips, the tongue. And when that happens, they have to come off of that medication because that can interfere with their airway and constrict their breathing. Okay? And that's it for the ACE inhibitors, the prils. Next, angiotensin receptor blockers, the ARBs. Think about it. ACE inhibitors block angiotensin converting enzyme, so they stop that system in the kidneys. ARBs, angiotensin receptor blockers, do it but like in a different way. Same kind of ending is that they don't have antidiuretic hormone, and so a little bit of fluid is not held onto, and so blood pressure comes down. Basically the same side effect. Don't cause the cough. ARBs don't cause the cough, but ARBs can cause angioedema, and they can cause hyperkalemia. So those are the things to look at. And the ARBs are the sartans, low sartan, val sartan. They're the ARBs. So when you see that, trigger your brain. The sartans are the ARBs, okay? The next classification of drug that we're going to review will be, can't forget about eplenorone, which is also called Inspra. This one's relatively new, but you do need to know it because ATI will ask you about it. So eplenorone is an aldosterone agonist. Same system in the kidneys, but at a different spot, okay? Renin, angiotensin 1, angiotensin 2, aldosterone. So this drug blocks that aldosterone and thereby same outcome, right? Blood pressure comes down because of peripheral resistance coming down. And it also causes hyperkalemia. Make sure you know that, okay? Okay, and that's the only drug in that classification that you need to know. Next, we're going to do the beta blockers. B, beta blockers. Number one, adverse effect potentially, bradycardia, because B stands for beta blockers and B stands for bradycardia. So beta blockers and calcium channel blockers work a little bit different. They do lower blood pressure, but they affect the heart first. So by doing that, subsequently then blood pressure does tend to come down. So the beta blockers are the laugh out louds, the LOLs, okay? Metoprolol, bisoprolol, atenolol, propanolol, and they have commonalities as well. So bradycardia, right? We talked about that, and they can cause heart failure. So if you have a patient that just started taking a beta blocker and they come for their follow-up checkup and suddenly they have signs and symptoms of either left or right-sided heart failure, left-sided like pulmonary edema, right-sided peripheral edema, jugular vein distension, all of those things, that's a problem. You need to stop the drug, contact the healthcare provider, okay? So, and then also, just so you know, ophthalmic drops, timolol is a beta blocker that is used for glaucoma. And don't forget this little tidbit. Whenever eye drops, ophthalmic drops, are administered to a patient, especially a beta blocker like timolol, you must put pressure to the lacrimal duct, the tear duct, after the administration of the drop. Why? Because beta blockers cause bradycardia. Just because it's ophthalmic, it can do the same thing systemically, cause the patient's heart rate to drop. And so you don't want the patient to have systemic side effects from that medication. Pressure to the lacrimal duct solves that problem, okay? All right, very good. The next set of medications that we'll talk about are the calcium channel blockers. And here, unfortunately, there's, a little bit of a commonality, but, you have nifedipine, amlodipine, felodipine, but then you have verapamil and diltiazem. Really, the one you want to be cognizant of is amlodipine, which is Norvasc. So calcium channel blockers, kind of similar with the beta blockers. They kind of work on the heart, and then subsequently the blood pressure comes down. Calcium channel blockers do not like grapefruit juice. There's another drug that grapefruit juice is a no-no, okay? So make sure you know that. It can actually cause the patient to become toxic. All right, the next one on our hit list is the nitrates, which are vasodilators, and the big one, nitroglycerin. There is another one that's called Imdur, isosorbide, and you'll see that it's on the PowerPoint. But I'm going to talk about nitroglycerin. So nitroglycerin can be administered sublingually, buccally. That's the fast-acting, right, for angina. We also have transdermal patches of nitro, and we also have nitro paste. We can give nitro IV. I mean, nitro is like, woo, does a lot. So it's a vasodilator. In other words, when it's given, it works to relax all the blood vessels in the body. When they relax, they dilate a little bit, and blood flow is easier, okay? So let's talk about sublingual nitro. So that is the little brown bottle, glass bottle. It's got to be kept in that little brown glass bottle. Never put it in a different container. It's sensitive to light. That's why the bottle is glass. You have to keep it in a cool, dark place. Renew it every 6 months, whether you used it or not, because it does lose efficacy. Efficacy means effectiveness. Patients can actually use this prophylactically. So if a patient has angina, let's say that, poor old Mrs. Jones down the street, she doesn't really get her angina very much, but when she vacuums, then she tends to get it. Well, she can take the nitro prophylactically about 15 and 20 minutes before that activity to help to prevent the angina and the anginal attack. A couple things that you need to know about sublingual. Patient can take 1 dose sublingually every 5 minutes for a maximum of 3 doses. If there's not relief of the chest pain or angina after the first dose, they need to call 911. Not after the second dose, not after the third dose. After the first dose, they have to call 911. Not their Aunt Millie or their neighbor down the street to bring them to the hospital. Why? Because if they are having a myocardial infarction, Aunt Millie probably doesn't have advanced life support skills, but the paramedics do. So, no relief after the first dose, call 911. They may still take the second and third dose while they're waiting for 911 to get there. So, tingling of the tongue is kind of expected. That means it's working, so that's not a big deal. Patient will have a drop in blood pressure, orthostatic hypotension. All the blood vessels are now wide open, so blood pressure is going to come down. Instruct the patient, don't rise quickly. Matter of fact, they should just stay in a seated or lying position when they're doing this, when they're taking the nitro. Common side effect, headache. Again, it's increased blood flow. Vasodilation, you've got blood flow, and the blood flow is going to the brain. If anybody that's ever hung upside down knows when the blood rushes to your head, headache. Not a big deal, usually gets better over time. And if it's not contraindicated, a simple acetaminophen, Tylenol, will usually help with the headache, okay? If the patient's got a dry mouth when they're getting ready to take sublingual nitro, it's very important to have them take a sip of water, suck on an ice cube or something to get the mouth moist or else that sublingual tablet won't be able to dissolve effectively in the mouth, okay? So don't forget that. When we talk about the buccal, that's really the same things apply except for the dry mouth, because buccal nitro, little spray bottle, squirt bottle, and it's squirted into the buccal cavity, which is between the cheek and gums. You know, we're baseball players and rednecks that chew tobacco, right? So that's the buccal. With transdermal nitro, it's important to remember, and just like with any transdermal patch, okay? The transdermal patch should be on a hairless area or the least amount of hair as possible, but never shave the hair off of a patient's body. That's a no-no. It's a risk for infection. Site should be rotated every day so that there's not irritation to the site. You can use anterior chest wall. It's a common site. It's on during the day and off at night. So when you wear gloves, you apply the patch. You should be putting your initials and the date and time on the patch. So this way, whatever nurse follows you will know what time it went on and will know what time to take it off. Same side effects as far as, blood pressure will drop, et cetera, et cetera. And I think that's it. Oh, for the men out there, most blood pressure medications will generally cause erectile dysfunction. And my own personal opinion doesn't reflect the opinion of Rhythm Career Institute or any other school or anybody else, or any of their affiliates. A man would rather have a stroke or a heart attack than not be able to have sex. So Viagra, sildenafil, is an erectile dysfunction aid, but they cannot take that with nitrates. Okay? It can drop their blood pressure so low that they can actually not recover and they can die. So they cannot take sildenafil, which is Viagra, with nitrates, nitroglycerin, or isosorbide. Okay? Make sure you don't forget that. ATI question. Okay. The next medication that we are going to go over, or group of medications, well, this medication is not a group. This is kind of a standalone queen mother, if you will. Digoxin. Digoxin is a cardiac glycoside. It's an unclassified antiarrhythmic drug. So what it does is it slows down the heart, and when it slows down the rate of the heart, it increases the contractility of the myocardium, so it makes it beat better. It functions better as a pump with Dig. Remember, a lot of things to know about digoxin. Number one, you must take an apical pulse for a full 60 seconds, okay? So left mid-clavicular line between the 5th and 6th intercostals is where you place your stethoscope, and you must listen for a full 60 seconds. If the heart rate is anything less than 60 beats per minute, for adults, hold the Dig. You do not administer the Dig because it's going to slow the heart rate down even more. Digoxin is one of those drugs that we have to do serum levels on, blood tests, and the therapeutic level for digoxin, 0.8 to 1.2. If they hit 1.5, they're heading towards toxicity, and anything greater than a 2, they're toxic. Early signs of Dig toxicity, like many other drugs that can make you toxic, are GI upset. So nausea, vomiting, anorexia, loss of appetite. As it progresses, if we don't notice it, it can then become things like green or yellow halos around objects in the visual fields, blurred vision, visual disturbances, severe bradycardia, and even lethal dysrhythmias. So it can be very dangerous. Big risk factor for Dig toxicity is hypokalemia. So if the patient's on a medication that is potassium wasting, like a diuretic, okay, they're going to be a higher risk for Dig toxicity. So you're going to want to watch them even more carefully, okay? Don't forget that. And I think that's going to be it for digoxin. And the next group of drugs, and these are fun. So these are the anticoagulants, and then I'm going to do the antiplatelet aggregating drugs. I kind of lump them a little bit together at the end here. So anticoagulants, remember, we're nurses. They don't thin the blood, okay? They're not blood thinners. They are anticoagulants. Anticoagulants. Coagulate means to clot. So these are drugs that slow down the blood's ability to clot. And they do it different ways. The first one we'll talk about is heparin. Heparin is kind of the queen mother, if you will, of the anticoagulants. Been around forever. Heparin is given either subcutaneously or IV, and it's quick acting. So if a patient comes in and we think maybe that they're having a stroke, or we need to, they're in sustained AFib and we're afraid they're going to throw a clot, I can start a patient on heparin and it's going to work right away. Right away. There's no waiting period for heparin. So it prevents blood clots from forming. Now, it does not destroy existing clots. Make sure you understand that. All the anticoagulants do not destroy or break down existing clots. If there is an existing blood clot, they will prevent them from becoming larger, and they will prevent the formation of any new blood clots. Okay, but that's where it ends. With heparin, the blood test that needs to be done is the PTT, also called APTT, and PTT stands for partial thromboplastin time, or activated partial thromboplastin time. And what it should be, I'm just going to give it to you. It's in seconds. So how many seconds does it take the blood to clot? And therapeutic PTT for heparin should be somewhere to 60 to 90 seconds. 60 to 80 seconds, considered therapeutic. If the patient becomes toxic or has a high level of heparin in their blood or starts to bleed, hemorrhage, which all anticoagulants potentially can cause that, the antidote for heparin is protamine sulfate. Make sure you know that. That is a board question. The antidote for heparin, protamine sulfate. The next drug we're going to talk about is warfarin, also called Coumadin, also called Jantovin. So that's an oral anticoagulant. That's a slow-acting one. And so what you may see very frequently is patient gets admitted and they need to be anticoag quickly, but we also are going to send them home in a few days. We will start the patient on heparin and warfarin. And while we're waiting for the warfarin level, the PT-INR, to become therapeutic, we'll have them on both of those drugs. So that's the reason. Once the warfarin level, INR is a 2.0 to 3.0, is therapeutic, we can stop the heparin and send the patient home on warfarin. Okay? Make sure you know INR, International Normalized Ratio, is what that stands for. It's an international way to test only for Coumadin, warfarin, and therapeutic should be 2.0 to 3.0. And then PT is prothrombin time, and that's kind of like the PTT is for heparin, but measured in seconds, a little bit different. So prothrombin time should be 11 to 13 seconds. And if they are on Coumadin, in order for them to be therapeutic, it should be somewhere around 18 to 24 seconds. And takes about a week to work. And if for some reason they hemorrhage or they have an issue with their INR being too high, vitamin K is the antidote. Phytonadione, vitamin K, is the antidote only for Coumadin. And make sure that you teach the patient about food sources that contain vitamin K. And by the way, don't confuse vitamin K, which is represented as a K with a positive sign after it, a plus sign. It's an electrolyte. Don't confuse vitamin K and potassium, right? Potassium is the K with the plus sign. Vitamin K is a fat-soluble vitamin that's stored in the liver, by the way. And so foods that contain vitamin K, the primary sources are the green leafy vegetables. You want to teach the patient to eat consistently. So in other words, if the patient says, I go to bingo twice a week and then I go with my girlfriends and have a spinach salad, fine. Just make sure that you keep that same routine every week. So if you're going to have a spinach salad twice a week, always have a spinach salad twice a week. If they fluctuate greatly with their intake of vitamin K, we're going to see these huge fluctuations in their INR, and we're not really going to know how to dose them. Okay, so make sure that they understand that. Don't forget about the other anticoagulant, enoxaparin. It's a low molecular weight heparin. Trade name is Lovenox. That is given subcutaneously, and that is the one that you will most likely see prophylactically for DVT prevention in patients that are post-op, say after orthopedic surgery. They had a hip, they had a knee, cardiac surgery, right? You'll see them on enoxaparin, okay? Now, antiplatelet aggregators. So your platelets, which are your thrombocytes, are another thing that helps the blood clot. And there are antiplatelet aggregators, and the two big ones that you need to know, good old aspirin, salicylic acid, and the other one is clopidogrel, which is Plavix, okay? So they're not anticoagulants per se, they're antiplatelet aggregators. They prevent platelets from getting stuck together and forming clots. They still can cause, there's a risk of bleeding that goes along with them, but it's not as high a risk as it is with the actual anticoagulants. So you'll see people say on a low dose aspirin daily, 81 milligram. Well, that's not because they're in pain or they have a fever. It's for heart health, right? To prevent the platelets from clumping together. You want to make sure that they understand, there's a risk, especially with aspirin, of GI bleed. So tell the patient to be aware of their stool. If they start having black, tarry-looking stools, they need to contact the healthcare provider. That's called melena and can be a sign of a gastrointestinal bleed. When patients are prescribed the aspirin, low-dose aspirin or full-strength aspirin daily to prevent MI, myocardial infarction, oftentimes they'll be prescribed enteric-coated. Ecotrin, right, is a very common one. So it's enteric-coated, so it doesn't break down in the stomach, therefore it's less likely to cause GI upset, less likely to cause a GI bleed. With all these meds, the anticoags and the antiplatelet aggregators, understand patient teaching, risk for bleeding. They must use a soft bristle toothbrush because their gums can bleed. They must make sure they never use anything sharp, no razors to shave, electric shavers only, and that's male and female. You must make sure that they're safe at home. There are no throw rugs with electric wires under them, that they're going to fall, hit their head, and possibly have a subarachnoid hemorrhage, bleed right inside their head. It's really good practice for patients that are on anticoagulants, especially to wear a medic alert bracelet. Because if they're in an accident and they're unconscious and they're not able to tell us what they're on, they come into the emergency room like this, it would be great for me to know that the patient's on warfarin by looking at that medic alert bracelet. So I know I don't want the patient to bleed to death. I can give the patient vitamin K to counteract the effect of the warfarin, or protamine sulfate to counteract the effect of heparin. So that's important for you guys to know. I think that's it for the cardiovascular meds. We covered every base there, and they're the ones that you have to know. All these things that I talked about, right? Just like with the boot camps, these are the things that you got to know. So more to come, system by system, and I will see you later, alligator. Bye.